And depending on the estradiol level, you need to watch for endometrial hyperplasia. If the estradiol level is high, you have a higher risk of building up the lining of the endometrium. Progesterone should be given cyclically, because if you give it continuously, like the birth control pill, you increase the risk of insulin resistance. That's why we have to check blood sugars on women who are on the birth control pill. And estriol may benefit in times of high estrogen. Postmenopausally, you want to give transdermal estradiol. You want to keep the estradiol levels low and watch the metabolism, make sure it's going down the right pathways. You can give progesterone orally or transdermally, but if you give it orally, you may get the allopregnanolone brain effect more than you want. Progesterone can be given continuously if estrogen doses are low. That mimics what Mother Nature does. So does Mother Nature give progesterone continuously after menopause? Yes, because it's coming from the adrenals. It's constant until the adrenals crash, and then you don't have it, so you need to give it. And IGF-1 and insulin, the peptide growth factors, stimulate cancer cells. Insulin increases IGF-1. It is anti-apoptotic in breast cancer cells. It and estrogen are synergistic in the breast. It's a double whammy, a double bad thing. The progestins facilitate the crosstalk between IGF-1 and estrogen. And IGF-1 levels increase with high estrogen levels, increase the risk of breast cancer. And IGF-1 inhibits sex hormone binding globulin. Woo, what happened? Okay, wait. All right, I'll find it. In the liver. Now, what about testosterone in breast cancer? Well, I showed you this morning that if you increase testosterone, you decrease sex hormone binding globulin, you release estrogen, and you may increase the risk of breast cancer. And testosterone is converted via aromatase to estradiol. So if you have high testosterone and high aromatase, you're going to get more estrogen. So be careful about giving testosterone. Okay. So what are the signs and symptoms? Well, a common symptom of women with risk for breast cancer is they've had previous breast biopsies. And I think that just means they've had a bad environment there. It's been going on for a while. They have a pear body shape, the estrogen body type. They have breast tenderness. Breast tenderness means something's going on in the breast. I don't allow breast tenderness in my practice. Not allowed. They have dense breasts. Those are breasts that are inflamed and stimulated by estrogen. They have menorrhagia that says they have too much estrogen. They have large breasts. They have a large field. And they have obesity after menopause. Why is obesity after menopause a problem, but obesity before menopause is not a problem for breast cancer? You should be able to think this out after this morning's lecture. So what did I tell you? Where did I tell you the estrogen comes from postmenopausally? It comes from fat. So postmenopausally, fat matters. Premenopausally, you get really high levels of estrogen that comes from the ovary. It travels around in the bloodstream, and the contribution of the fat is relatively unimportant. So obesity doesn't mean that being obese before menopause is a good thing. It just means it doesn't affect your estrogen levels as much. So what are the common ATMs? Genetics, inflammation, too much estrogen, xenoestrogens. radiation, toxic exposures, iodine deficiency, and the wrong diet. And then this, you can get this feed-forward issue of diet, toxic exposures, and stress producing high estrogen and low progesterone. So what are the metabolic considerations? They're everywhere. Every single node on the matrix has issues for women who are at risk of breast cancer. You can look at each one of those. That means there are lots of places that we can intervene and lower the risk of breast cancer. Lots of places. What lab work? Well, I get hormone levels, and I measure sex hormone binding globulin. Sometimes I do urine, and sometimes I do serum metabolites. I like to know if they can methylate, so I check homocysteine. You can look for inflammatory markers, HSCRP, ferritin. There are a number of inflammatory markers. Vitamin D helps to decrease inflammation. If their vitamin D levels are low, they have a higher risk of breast cancer. Iodine. It's difficult to decide how to measure iodine. Most of the studies are spot urines or 12-hour urine iodines. There is a provocative test for iodine, but it may not be as good as the laboratories say it is. 8-OH-DG, the measurement of 8-hydroxydeoxyguanine, a particle of damage to DNA. Lipid peroxides, and measuring the toxins. Looking at the genetics for those SNPs that affect the biochemistry that we talked about this morning. And looking at beta-glucuronidase in the stool. So this is kind of a workup that I do for somebody who is at risk for breast cancer, or wants to avoid breast cancer, or who's had an episode of breast cancer. And based on that knowledge, how do you intervene? Well, you need to improve estrogen metabolism and assure that normal or low levels of estrogen, depending on the patient's age and time since the diagnosis. I think initially you want to treat the cancer. You've got to get rid of the original tumor. Then you want to change the field. You want to change the environment that that cancer is grown in, so you can keep from having other cells become cancerous. Then you need to look at the long-term outcome. 80% of women who are diagnosed with cancer right now live a long time. They live longer than 10 years. So we need to be thinking about the health of those women beyond 10 years. And having very, very low estrogen levels is not healthy. We know that from women who had their ovaries removed in their 20s and 30s. We want to prevent oxidative damage to DNA. We want to decrease toxic exposure and do gentle detoxification, particularly in patients who've had cancer. You don't want to release a lot of toxins. I see a lot of women who do a sudden, rapid weight loss. They lose 50 pounds, and the next thing they know, they've got breast cancer. But what did they do? They took all the toxins that were stored in their fat and released them into their body. Not a good idea. So a consistent, slow weight loss program would be better. Help them decrease toxic exposures. Help them prevent insulin resistance by changing their diet so they don't become insulin resistant, or if they are insulin resistant, they convert that back to normal. Sugar is what cancer cells eat. It's that simple. If there's sugar around, cancer cells love it. So if you don't want cancer cells growing in your body, you want to be very careful putting sugar in your body. And mind-body interventions to lower stress, because we know stress unbalances hormones. And of course, I would be remiss if I didn't remind you that there are prenatal factors that are important in breast carcinogenesis. So let's talk about a case presentation of too much estrogen. So this is a 47-year-old married female. Her chief complaint is breast tenderness and heavy periods. What do we know about her right away? Too much estrogen, right? Her other symptoms are hot flashes. Well, if she's got too much estrogen, why is she having hot flashes? She's got too much adrenaline. Weight gain, so her adrenaline is already rolled over into high cortisol and maybe high insulin, and irritability. And so she's wondering, because of her heavy periods, if she should have the endometrium ablated, burned out, to get rid of the bleeding. And my answer is, well, why would you want to do that? Your endometrium is going to help you know that you're treating your estrogens poorly or correctly so that you can avoid the breast cancer. So your first impression should be she's got too much estrogen, not enough progesterone, probably. She's still having periods. She may have insulin resistance, adrenal fatigue. And so what are you going to do first? Okay. Here's where you get to tell me what you've learned this week. What's the first thing you want to do? Go to the matrix, right? Treat the matrix first. So we're going to look at her diet and exercise. We're going to look at her stress levels. We're going to look at her gastrointestinal function. We're going to address inflammation. What lab testing do you need? Well, I would like to know with this woman, does she have insulin resistance? So I'm going to do a fasting in 2-hour glucose and insulin. If her 2-hour insulin is more than 50, she's insulin resistant until proven otherwise. I'm going to check her thyroid and her adrenals. And I'm going to check her female hormones to see, does she have too much estrogen and how is it being metabolized? So what's your approach to lowering estrogens? Well, you've got a long list of things from this morning that should help you lower estrogen. You decrease aromatase by addressing inflammation. You improve the 2:16 ratio with things like indole-3 carbinol. You improve phase 2 detoxification with sulfate groups and with methylation factors, B vitamins, glutathione. And you improve excretion with plant-based diets and fiber. And how do you increase her progesterone? Well, the main way to increase her progesterone is to decrease her stress, right? So that she's not stealing progesterone away to make cortisol. And then improving her insulin resistance so that she ovulates better and makes more progesterone when she ovulates. And then you can give her herbal support of her ovulation. Vitex agnus castus, Vitex, can help increase progesterone production. And then you may need to give her progesterone if she's perimenopausal. You may want to suppress ovarian function with birth control pills, but be careful with that because you're going to initially stimulate more estrogen, and you're also going to be giving her artificial progestins and increasing her risk of insulin resistance. So while this is one of the things that you often see used, it's not my favorite. I might use progestins to empty out the uterus and get the heavy bleeding under control. So what are the results? Well, We lowered her estrogen. We improved her balance of estrogen and progesterone. She returns with decreased menstrual periods and less cramping. She has improved digestive function with regular bowel movements because we did a 5R program. And that's all produced less estrogen effect, so her breast tenderness is improved. And she's no longer contemplating surgery. You've saved her a potentially dangerous surgical procedure. And you've gotten her interested in being healthy, in eating better and exercising more, which may change her long-term trajectory. By addressing her perimenopausal estrogen excess, using a functional medicine approach, you may have added years onto her life, allowing her to become a grandmother. We have two ways of passing on what we have to our children and grandchildren. One is to pass on our genes. The other is to pass on our memes. Memes are infectious ideas. Because memes are just as important as genes, grandmothers and grandfathers are maybe the most important thing in terms of the prolongation of our species, passing on those infectious ideas. Okay, let's talk about osteoporosis. Osteoporosis is a too little estrogen picture. So different countries collect data differently. And could somebody tell me what time this talk is supposed to end? Is it 2:15 or 2:30? Okay. Okay. I'll try to get this done. So different countries collect data differently. It's hard to compare them. There's a large variability in access to reliable bone density data. Many countries don't treat fractures in hospital, and so they may underestimate the number of fractures. And these are worldwide statistics on osteoporosis, and you can see that in China, the prevalence of osteoporosis is 7% of all adults, 22% of men, and 50% of women over age 50. So a lot of women in China have osteoporosis. And there are not very many DEXA machines in China looking for low bone mineral density. There has been a 300% increase in osteoporosis in China in the last 30 years. Part of that is due to the aging of the population, and some of it may be due to the toxins in the environment, particularly heavy metals. Remember, heavy metals are stored in bone. Your body sees a heavy metal, it says, well, this is dangerous. I can't have this running around. Let's put it somewhere that's not as metabolically active, and it puts it in bone. But bones are not metabolically inactive. There's turnover going on in the bone, and if you poison that turnover with mercury and lead, it doesn't happen, and then the bone becomes fragile and it breaks. 40% of women over 50 will suffer a fracture. Not all fractures are due to osteoporosis, however, and so not all of them are preventable by using anti-resorptive drugs, for instance. The high mortality following hip fracture is not always due to the hip fracture. So we see a high mortality in people who've had a hip fracture, but sometimes that's due to the fact that the brain was already in trouble and so she fell, and that's why she fractured her hip. And so what was making her brain not work right is also going to be the thing that kills her. So she's got dementia, she's got bad cardiovascular disease, she's having syncopal episodes. That's going to kill her. And 50% will have long-term sequelae, and 25% of those will need long-term care. It is true that osteoporotic fractures produce a lot of requirement for health care and cost to the healthcare system. Since in many men and women the hip fracture is due to a fall, and is a symptom of a failing brain or eyesight or muscle strength, it shouldn't surprise us that death follows the fracture in many cases. It may be that the death is following the cause of the fracture and not the fracture, however. So osteoporosis fractures are related to bone flexibility and strength as well as the amount of calcium in the bone. They are related to muscle strength. Can you catch yourself if you start to fall? If you fall and land on some padding, you may not fracture, but if you're very thin, there's no padding. And how often you fall, your neurological situation can determine whether you get a fracture. So why are fracture rates less in China? Well, the aging population is increasing in both countries, but the percent of elderly is increasing faster in China. So that you have fewer fractures, but it isn't going to last. Smaller bones break more easily. You're going to have trouble with that. More physical activity in China may be useful because you have more physical activity. I'm sorry, small bones break less easily. So if it's a small bone, it doesn't break as easily. More physical activity in people in China may help you. A better diet, you eat more vegetables, adding vitamin D and calcium, the right amount of calcium. Getting it from your food is preferable. Less caffeine. You drink tea, but tea has tannins that keep you from absorbing the caffeine. Less milk and milk proteins in the Chinese diet can be helpful. And perhaps less gluten sensitivity. Turns out gluten sensitivity and gastrointestinal inflammation are strongly linked to osteoporosis in the bone. So prevention of fractures with drugs could be more expensive than treatment with other approaches. So here's what happens with the drugs. This was a study that showed that older women with a fracture are the only ones that the cost of preventing the fracture is worth doing. So younger women without a fracture, you had to spend $450,000 to prevent the fractures. Younger women with a fracture, you still had to spend $90,000. They say that if you're spending more than $40,000 to prevent an event, it's an unreasonable use of resources. So these are the osteoporosis drugs. They're not cost effective. Prevention of fractures, falls produce 90% of the hip fractures, and so preventing falls may be a better way of preventing fractures. So how do we prevent falls? Well, we have to be doing weight-bearing exercise, keeping the muscles strong. We need to keep the vision healthy so we don't trip over things. And we need to keep the brain healthy with some of the approaches that Dr. Hanaway gave you yesterday. And urban populations have more fractures than rural areas because they don't get as much exercise. So unless you're walking a lot in your cities, if you're traveling by car like we do in America, you're not going to get as much exercise, and you're going to have more trouble with osteoporotic fractures. So here are some relative risk of fracture issues. Age is a big one. A maternal history of hip fracture. If your mother had a hip fracture, you're more likely to have a hip fracture. If you've been hyperthyroid, if you're using drugs that make you fall, if you drink caffeine, you have an increased risk. But if you're walking for exercise, you have a decreased risk. If you can't get up from your chair without help, you don't have enough muscle mass to keep from falling. And if your resting pulse is over 80, you're not getting enough exercise, and you've got an increased risk. So here is the functional medicine matrix. And you can see there are issues in every node of the matrix. So once again, there are things we can do to prevent osteoporosis. We can address inflammation and gluten sensitivity. We can treat hormone inadequacy. We can treat inflammation. We can treat the unhealthy brain and vision to prevent falls. We can treat heavy metal toxicity. We can improve diet, exercise, stress reduction. And by the way, marital violence is not an uncommon cause of fractures. So women get more fractures because they don't have as much bone to begin with, so we hit the point where fractures are likely to happen sooner than men do. It's not that men can't get there. They just don't get there as soon, and they're more likely to die before they get there. Now, I thought this was interesting. It said the first fracture you're likely to have is the Colles fracture of your wrist. So when women say, I had a bone mineral density and it showed that I have very low bone density, and they want to put me on drugs, and I don't want to go on drugs, I ask, have you had a fracture? If they've had no fractures, they've got time to change their diet and exercise program. If they've had a fracture, the first fracture you're likely to see is the wrist, and most people don't die of a wrist fracture. So I use that information to say if you haven't had a fracture yet, you probably have time to change things. Surgical menopause is more of a problem because you lose not only estrogen, but you lose testosterone. And here is bone formation. This is what happens if you replace estrogen and testosterone. And this is what happens if you replace estrogen only. This is bone resorption, this is bone formation. And this is the new data that suggests that gut inflammation and gluten are strongly connected to what happens in the bone. And then vitamin D, the 36th parallel is right here. So if you live in China above that line, like Beijing, between October and March, there's not enough vitamin D. And when you don't see the sun much, I'm not sure you get vitamin D the rest of the year either. So I suspect that vitamin D levels are quite low here. Would I be right? Do you see low vitamin D levels here? That's going to affect bone density. So measure vitamin D, give vitamin D3. You need to give high enough doses to get the vitamin D up. This is a pulsed dosing, which is thought to improve the levels and saturate the tissues faster. And don't forget to give vitamin A and K along with your vitamin D. So how do we treat osteoporosis? We heal the gut. We take them to a gluten-free diet, and we make sure they have enough calcium in their diet. We want to add vitamin D, vitamin K, weight-bearing exercise, and exercises to improve balance. Then estrogen, progesterone, and testosterone replacement, yes, if they're really low. If they need replacement to get them back to normal for age, I would give them. And the first drug that I give is calcitonin nasal spray, miacalcin. It is a more physiologic way to build bone. It doesn't build it as fast as alendronate, but it will build it slowly, and it's more physiologic. And the reason I don't give the bisphosphonates is they interfere with bone turnover. So they block the normal remodeling of bone. And what that does is produces problems. And we began to see those problems with osteonecrosis of the jaw in women who had been on bisphosphonates. So now we're seeing these strange femoral fractures in people who've been on bisphosphonates for 7 years or more. So I don't think they're a good drug. They will improve bone density, and they will decrease fractures for a period of time, but then they begin to increase the fracture rate. there is parathyroid hormone as a rescue. So this is why I tell women if they haven't had a fracture, they've still got time to fix things. If they get to the point where they're really fracturing, you know, the little old lady in the nursing home where you turn her over and she fractures a bone, you can use parathyroid hormone. I would be careful giving this lightly because it does have an increased risk of bone cancer. Okay, I think I'm going to skip this little study. Okay. So, female hormones. Estrogen and progesterone, always keep them in balance. Estrogen and testosterone also need to be in balance. There's a very narrow range for balance, and if you get too much of one or the other, you lose the benefits of testosterone on things like libido. Progesterone and testosterone are balanced when there's normal adrenal function. So don't allow the adrenals to get out of balance. And you can treat women with diseases due to too much or too little hormone without giving hormones, if you know functional medicine. So that was a lot of information, and I apologize for going over a bit, and I hope you don't feel like this from getting too much information. Thank you.